on Dr. Basu Bose. He's our senior from CIP. So he'll be telling us about some of the recent developments. Yeah, in the transition of neurodevelopmental disorders to personality disorders. Next slide, please. Let me introduce and welcome Professor Dr. Tufan Pati sir. Sir is from Cuttack. Sir is the leader, chairman of this program, and sir, over to you directly.
Thank you, Alim. And at the outset, I welcome our team comprising of Dr. Alim Siddiqui and Dr. Amrit Parjoshi are the dynamic moderators in every session. Welcome, Amrit and Alim. Please proceed. Dr. Amrit Parjoshi from Bhubaneswar is Professor of Psychiatry in High Tech Medical College. Dr. Alim Siddiqui is from Lucknow and he is also Professor of Psychiatry in Niras Lucknow Medical College. Both are active members of IPS. Welcome. And now I have the pleasure to introduce our dynamic chairpersons. Our chairperson, Dr. Phanikant Kondopati. He is MBBS from SBS Medical College, Mehboob Nagar, Telangana. He did MD from Kaminin Institute of Medical Sciences, Telangana. Currently working as Assistant Professor of Psychiatry in Institute of Mental Health, Usmania Medical College, Hyderabad. He is General Secretary of Hyderabad Psychiatric Society, convener of Public Education and Awareness Subcommittee of IPS, and I had the pleasure of meeting him just a few days ago. Welcome, Dr. Phanikant.
Thank you, sir. Thank you so much.
Next, our other chairperson is Dr. Sandeep Kumar Goyal from Ludhiana. Dr. Sandeep Kumar Goyal is currently working as consultant psychiatrist at SPS Hospitals, Ludhiana. Previously, he was professor and head of the CMC Ludhiana. He is immediate past president of Indian Psychiatric Society, North Zone. He has written 16 book chapters and edited a multi-author psychiatry book for undergraduate medical students. He has 25 publications in national and international journals. You have such an enlightening personality with us, Dr. Goyal, as well as Dr. Phanikant. And our speaker is Dr. Soumya Basu. We are going to have a very highly productive session. Now, the meeting is over to the chairpersons. Chairpersons, please take over. Please, up to Dr. Goyal and Phanikant.
I think Dr. Goyal, he was a bit unwell, so he might not be able to join. So Dr. Phanikant has to do all the labor.
Shall I start the proceedings, sir?
Yes, sir.
Yes, Dr. Phanikant, to start the proceeding as well as you can introduce the speaker because the slide is
thank you so much, sir. Yeah. Good evening, one and all. Thank you, Tufan Pati sir, for your kind words and affection towards me. Yeah, I had the privilege of meeting you recently in annual conference of Orissa Psychiatric Society at Paradeep Port. It was very nice meeting you, sir. It was a very warm welcome also. Thank you so much. It's a privilege to be a part of this Thursday Musings series, and I'm glad to be chairing today's session on interesting topic, autistic spectrum disorders and other neurodevelopmental disorders and their transition to personality disorders into adulthood. Once again, I express my gratitude to the organizing team, Dr. Tufan Pati sir, Dr. Amrit Parjoshi sir, and Dr. Alim Siddiqui sir for giving me this opportunity. I welcome today's speaker, Dr. Soumya Basu, Associate Professor of Psychiatry. It is my honor to introduce today's speaker to the audience. Can I have a slide? Yeah. Dr. Soumya Basu is an Associate Professor of Psychiatry. He is a child and adolescent psychiatrist. He's trained both in India as well as Australia and has more than 20 years of experience in psychiatry. After doing a diploma in psychological medicine and MD in psychiatry in India, he went to Australia and gained his fellowship with the Royal Australian and New Zealand College of Psychiatrists. Dr. Basu, a clinical associate professor of Department of Psychological Medicine at Monash University, has undergone training to become a faculty member of the child and adolescent branch of this college. He is the coordinator of the child and adolescent postgraduate training program with Monash University. He has research interests in children of parents with mental illness, early intervention, developmental trauma, developmental disabilities including autism, early psychosis, and transcultural psychiatry. He has more than 40 research publications in peer-reviewed journals. Several of his research papers have been presented in national and international conferences. He's a consultant child and adolescent psychiatrist for the early in life mental health services with Monash Health, Melbourne. He is consultant in charge of the neurodevelopmental assessment unit and chair of MONDIR. MONDIR stands for Monash Neurodevelopmental Interdisciplinary Research. He is also the director of child psychiatry of Victorian Institute of Mental Health, where he leads multidisciplinary teams. Welcome, sir. Welcome to today's session.
Sir, you have to unmute yourself.
Soumya Basu, sir, can you please unmute?
Yes, I've unmuted myself. Can I share my slides now?
Yeah, before that, I would just give my introductory remarks now before your session. Can I?
Sure, sir.
Yeah. So I would just like to give few introductory remarks before handing over the session to the speaker. Today's topic is on ASD as well as NDD transition into adulthood, their personality disorders. We know childhood onset neuropsychiatric disorders, which include autistic spectrum disorders, adult ADHD, tic disorders, and learning disabilities, which has impact on temperament, character, and personality development. If we go hypothetically, neuropsychiatric diagnosis designate dysfunctional extremes of normally disturbed abilities. The variation in such abilities is partly constitutional and may influence personality development to a greater extent. In other words, certain childhood temperament profiles may impair healthy character development, producing personality disorders in adulthood. Every one of us is familiar with Cloninger's biopsychosocial theory of personality, which is based on the assumption that personality involves 4 temperament dimensions and 3 character dimensions. Every one of us, the 4 dimensions of temperament measure individual differences in the basic emotional drives, and 3 character dimension measures individual differences in higher cognitive processes. This model can serve as a tool for disentangling personality problems or disorders in subjects with neuropsychiatric disorders. With these few remarks, I request Dr. Soumya Basu to take over the session. So we are eager to listen from you the mystery of unfolding the transition to personality disorders in adulthood. Thank you, sir. Over to you, sir.
Thank you. Thank you for this invitation. And it's an honor for me to really participate in this group. It is Thursday musings for you, but it is Friday musing, Friday early hours, and it's at 1:30. I'm a bit drowsy, so if I am faltering, you have to take over, Dr. Panikat. And thank you for introducing that topic, and I think I can expand on this. And it's so lovely to see Alim and and Amrit today. They were my 2 of my very favorite junior residents. When Alim asked me to do this, I couldn't say no. And tomorrow I've taken a day off, so I think I'll be able to manage this. I'll just share my screen now. All right, so my interest in this field, I mean, I'm a child and adolescent psychiatrist. My main area of interest is autism spectrum disorder. And but it all started, this interest started while I was working in CIP Ranchi. I think I was a junior resident when in one day, while I was in the OPD, a 20-year-old male with tardive dyskinesia just came for the interview. And before the interview started, he said that if you just want to talk to me, you have to answer few questions. I have to ask you a few questions, and if you can answer those questions, answer any one of those questions, then I am going to talk to you, or else you can just buzz off. This man was wearing a singlet, a pull up, a Bermuda thing, 3/4 pants. He was wearing thongs, very disabled. Um, but he said, choose your topic. Is it politics or sports? I said, you can ask me questions on sports. He asked me, what is Bobby Fischer's mother's name? I knew Bobby Fischer, he was a chess champion. He had schizophrenia, so it was a relevant question. But to ask that question with that degree, I couldn't even imagine that someone can ask such a question. The second question was, what is when in 1974, when Bobby Fischer was playing Gary Kasparov, what was his first move? I told him I can type politics. I mean, if this was the level of the questions that you are asking, I mean, I should try politics. He asked me, what is the opposition party of New Zealand? And this is from Ranchi. I mean, if he was in Australia, that could have made sense. But in Ranchi, he was asking me this question about the detail of his knowledge. The second question was something on politics of Japan. But the fifth question, the last question that made my day and perhaps changed my career was, which country had the first prime minister, female prime minister? I said, Sri Lanka. And he said, you're not an idiot, I can talk to you. What happened after that was gradually, I thought this is not right. It is not, he had a diagnosis of schizophrenia. He was on injectables. He had developed tardive dyskinesia, but it was not sitting right with me. In CIP, we had a fabulous, infrastructure. We had psychologists. We had access to beautiful books and teachers. After long discussions and case conferences, we thought that this is perhaps the first case of Asperger's that we are seeing, and the patient was wrongly diagnosed. He actually could not finish his education. He went up to year 8, but he could do year 12 maths just looking at it. He got extremely bullied. He had significant problem. He got so severely bullied at school. The whole family was bullied by the community because of his eccentricities. And he did not have any symptoms of schizophrenia. But still, because of his eccentricities, he received a diagnosis of psychosis. And he was 20 years old. And that was such a fascinating. He wrote some papers on it. His IQ was spectacularly high, but there was a big difference between his performance and his verbal IQ. And he had major problems with his coordination. Interestingly, one thing that happened as well in CIP was, I don't know whether Alim and Amrit can remember this case or not, but he was quite a high-profile patient, and but he was a chess champion, but he used to be beaten once in a while by one of the ward boys, and he held the ward boy with utmost respect. And he famously told me once that I've got all the knowledge but no wisdom. His common sense was not that much. He used to make social gaffes a lot, but working with him closely really opened up a world to me, and I got hooked into this whole thing of autism spectrum disorder and how it manifests itself in adulthood. The Australian experience after coming here, strangely, I had to do adult psychiatry. I was working in child psychiatry for 3 years in India, but to get into child psychiatry, you have to pass the exam. So I had to work in adult psychiatry. And as a child psychiatrist and a wannabe child psychiatrist, I was only seeing child psychiatric problems in adulthood. And it was very interesting. There were cases after cases where patients had undiagnosed or really unrecognized or unacknowledged childhood conditions, including severe childhood traumas, ADHD, autism spectrum disorders that was not picked up. During the early days of 2000, from 2004 onwards, I've been here. There were cases after cases where people with neurodevelopmental disorders, adults with with adults with neurodevelopmental disorders will fall through the cracks. They would, if they don't have a major mental illness in adult psychiatry like bipolar or schizophrenia, sometimes severe personality disorders, they would not, they would really fall through the cracks in the public health system, and they would not be able to really afford private health. And then that was quite a issue. But then there have been funding issues too. For a number of years, all the fundings was associated with an early intervention, early diagnosis, and we had to make a diagnosis in children before the age of 6, which is often so hard, especially when you're thinking about high functioning autism. And that was the early days. Things have changed a lot, and I will be talking about that, and that is what we are experiencing in our research as well. Before, there is a substantial difference between the Indian system and the Australian system. We have community mental health. So the patients with emotional and behavioral difficulties who may or may not have a diagnosable psychiatric problems can be referred. Initially, at the lowest tier 1 level, there would be teachers or mental health professionals at school that can be of help. Tier 2 level consists of mental health services provided by professionals like counselors, psychologists, private practitioners, and then the child and adolescent mental health services. In Monash Health, we call it early in life mental health services, where the families with significant emotional and behavioral difficulties can get referred. The equivalent of this tier 3 service in adult would be the adult mental health services, where the definition is major mental illness. And there comes this problem. In child psychiatry, it is behavioral and emotional difficulties. In adult psychiatry, it is major mental illness. And hence, sometimes the patients who are making into child psychiatry might not transition into adult psychiatry. And often in our experiences, the most severe ones with severe high risk personality disorder, suicidal behavior that we have been managing in camps, when we are trying to transition it to adult psychiatry, they will not beat the cut because they don't have a major mental illness, and often there is a big gap in the services. The tier 4 services would be inpatient services or highly specialist services, and I'm a part of this highly specialist multidisciplinary assessment service where we cater to the population of 0 to 25. The youngest children that are referred would be sometimes under the age of 2, and the older ones are up to the age of 25. So this is a multidisciplinary autism or neurodevelopmental assessment team, when the main source of referral will be the patients in camps. When the camps clinicians are not being able to really figure out whether there is a neurodevelopmental element to the presentation, they refer these patients to us in the specialist services, and where the diagnosis or neurodevelopmental underpinning of the diagnosis is made. And often these patients are presenting with emotional dysregulation, trauma, and a complex psychosocial milieu, presenting with diagnostic conundrums that we need to really tease out. And interestingly, I think, in one day, I see only 2 patients, but for almost 3 hours for each patient, and then this patient would be undergoing speech assessment, where they would do the receptive expressive language and then pragmatic supralinguistics. Then they will also get an IQ test, and they will also be assessed for learning disabilities. They will also get an occupation therapy tests, where they would be tested for sensory sensitivities, coordination, fine motor coordination. So it's a comprehensive assessment. Then we will do a formulation together and then feedback. So it's quite an extensive process, highly specialist services. So most of this talk that I will be giving today is an experience from that highly specialist services. But I work in private practice, so I covered this tier 4, tier 3, tier 2. Just a little anecdote, services like NIMHANS or CIP or the national health, we don't have such systems in Australia at all. It would be something like tier 5, tier 6, which caters to so the experience from CIP and Ranchi is something unparalleled, as you can imagine, because these are so in Melbourne we would have this tier 4 services would be around 6 or 7 tier 4 services in the city of Melbourne. And it's all based on the different zones in a city. It's all geographically determined. The early intervention as a philosophy, Victoria leads the world, as you know. The work of Patrick McGregory and the early psychosis has been quite legendary for last 20-25 years. Victoria has led the way, but we have also learned from our mistakes. The whole youth mental health was introduced to our surprise as a child psychiatrist. At times I still feel quite surprised about the introduction of youth mental health services in my own service. Initially, it changed from 18 as the cutoff to 25, and then it has also again returned back to 0 to 18 to be child and adolescent, and then 18 to 25 as a youth services. The whole idea about the youth mental health was to prevent people falling through the cracks. So Victoria leads the way in this, but the biggest challenge also with youth mental health is major mental illness is defined, because most of this, when psychosis dominates the picture, even patients with severe self-harm behavior and recurrent suicidal behavior also do not miss out. And this has been a huge issue. There is the 0 to 25 initiative that has been launched in my state for the last decade. It is now being implemented with a huge amount of money being pushed in to a tune of billions of dollars being put in to really make changes in the mental health and how it is provided to the thing. In my health services, the youth mental health has the portfolio of personality disorders, and in their request, I developed this whole lecture and training program on which I will be using the slides from the training program that I've developed for the youth team for these lectures. Now, one of my great areas of interest, because I've had to work in adult psychiatry and child psychiatry. Most of you are working in that sort of a situation in India, I'm sure. But the transitional problems into adulthood is quite fascinating. And in Victoria, which leads the early intervention programs, it is still top down, to prevention of a psychosis. That is the biggest draw card. But as a child psychiatrist, my interest is about how do child psychiatric conditions move into adult psychiatry, and why do we need to really understand those child psychiatric conditions better to understand the adult. The overview of the presentation would be neurodevelopmental disorders, the environmental factors and its influence on the biology, girls with neurodevelopmental disorders. Most of the research, the entire body of literature, 95% is on boys with neurodevelopmental disorders and developmental trajectories. But it's a recent phenomena that girls with neurodevelopmental disorders are being understood better and better as we are entering the 20, for the last decade or so, there has been such a huge interest in this area. Then I'll talk about developmental trauma and autism spectrum disorder and understanding emotional dysregulation in childhood. That would be one of the cornerstone in understanding what's actually going on. And then there's the symptomatic and neurobiological overlaps in the construct of personality disorders and neurodevelopmental disorders. But the most important thing is importance of a formulation. More than the diagnosis, the importance of formulation will be emphasized. When we just a bit of a recap, types of continuity in psychiatric disorders, we have got homotypic continuity. The typical example is intellectual disability. That was a classic example that was given. But then as people grow older, that gene environment interaction happens, and there would be heterotypic continuity. The classic example of heterotypic continuity is ADHD. ADHD is a child, as they grow up they collect so much of emotional and environmental invalidation. They develop opposition defiant disorder. Then the opposition defiant disorder may or may not turn into conduct disorder. Sometimes it morphs into anxiety, depression, and in boys, antisocial personality disorders. And there is a strong evidence that is coming through about girls with inattentive ADHD and ADHD turning into borderline personality disorder. So so the continuities of child psychiatric disorders are really interesting. This is one of my favorite examples that I normally use in Australia to show off our cultural heritage. Is perhaps one of the greatest trilogies about human development, about transitions, is in this trilogy of Pather Pachali, Aparajito and Opu Sangsar, where the Satyajit Roy trilogy written by Vibhuti Bhushan Bandyopadhyay. Ultimately, he develops mental illness, but he went through severe trauma, but he never gave up. And it also talks about resilience and the early childhood factors, perhaps, which was responsible for his resilience. But the transitions, there's no other movie in movie history which goes through a human life through this sort of a lifespan. This is another slide about anxiety disorders. What is normal anxiety? What becomes clinically relevant anxiety into late childhood, and then the transitions of this anxious temperaments into adulthood, and how an anxiety disorder can become social phobia, and the social phobia can lead to anxious avoidant personality disorders into adulthood. So child psychiatric disorders are so interesting because the normality changes as we grow older and older. What is normal for a 3-year-old is so very abnormal for a 6-year-old, and there is no other lives in other lifespans. Those things are not that rapidly changing. The major challenges in the neurodevelopmental disorder field, especially in autism, is the changing of definition. The definition of autism spectrum disorder of 1980s is totally different from how we define autism spectrum disorder now. The whole conundrum of ADHD and autism spectrum disorder, before DSM-5, we could not diagnose ADHD when there was autism spectrum disorder. So as you can see, the research and the cohorts that we are really following up are all changing. We at Monash Health, we have a cohort of 50 patients that we are following for last 30 years. They were diagnosed using DSM-3, and one of my colleagues, Kylie Gray, is highly cited authority on autism spectrum disorder. She is following adult outcome of autism spectrum disorder and major mental illness, which does not include personality disorder. So this is what we are dealing with. We are dealing with research, publications after publications, follow-ups of patients, but often because of the definitions have changed, we are there's so much of missed opportunity in research. And the longitudinal studies on autism spectrum disorders, and this whole generation, especially generations of girls who have missed out on what is going to happen to them in the future. that we are seeing now, and what we are seeing in clinics. I mean, the research department is next to the clinic, and the clinical experience is totally different from what we are researching. The research is a lot behind the clinical experience. And as neurodevelopmental disorders, as introduced by our chair, it consists of intellectual disability, autism spectrum disorder, ADHD, speech and language disorder, tics, Tourette's, developmental coordination disorder, very important. And this non-DSM, diagnosis of non-verbal learning disability. Yeah, I don't know in India whether you've got audiologists or not. We are here, we get a number of patients being diagnosed with auditory processing disorder, sensory processing disorder, who clearly will have inattentive ADHD, which is not picked up till late. They will have all sorts of auditory devices and inputs from an audiologist, but often there's a misdiagnosis of inattentive ADHD that happens in this sort of a situation. Now, as far as autism spectrum disorder is concerned, as you can see, there is almost an epidemic of autism spectrum disorder in the Western world. I don't know. I don't have any idea about prevalence in Indian context, but this is what has happened in the West, including Australia. In the latest, this is 2009, and then this is what has happened after 2009. This is the percentage of increase in diagnosis from 2010 onwards. And as you can see, there is a over-diagnosis. Usually, this increase has been about 700 times increase in the diagnosis over the age of 19. So in the adult population, there is an over-diagnosis. And look at what is happening with females. From 2007 onwards, this is what is happening. There is a 700 times increase in the diagnosis of mainly adults, and then that too females with autism spectrum disorder. And this is happening in the West, and many of them have already been diagnosed with borderline personality disorder or other personality disorders, which are being re-diagnosed as autism spectrum disorder. And why is this increase? Is there an epidemic going on? There is definitely the change in diagnostic classification. DSM-4 was drastically, there were 2,000 ways of diagnosing autism spectrum disorder, 4,000 ways of diagnosing autism spectrum disorder using DSM-4. The cost of autism in America was $90 billion. To just control that, they brought in the DSM-5 criteria. The entire research has been, the ADIR, ADOS, all those things are normed by DSM-5. The early research coming through about using the DSM-5 as a criteria. The diagnostic classification, a broader diagnostic classification, has definitely increased, especially on the other end, not the Canarian autism, not the low-end autism, but the high-functioning, normal intelligence or highly intelligent autism. That diagnosis have gone out, high. The spectrum terminology with high uptake and broader, and this caused a lot of destigmatization. And as you can see, there are Netflix series on Sheldon and young Sheldon and The Good Doctor. There are Love on the Spectrum, significant, one condition where people can act as an autism and make millions of dollars just. And it is quite a less stigmatized sort of a condition. There's increased public awareness, more people seeking assessment, and push for an early diagnosis when the behaviors are less defined. And I have faced it. There was funding associated to the tune of, say, $16,000, 8 lakh rupees of money for early intervention for a diagnosis before the age of 6, and especially with high functioning autism with good language skills. It is extremely difficult thing to do, and when you are not making a diagnosis, they will not get the money, and they will not get any speech and speech and OT and all these things which can really benefit. So there was such a big pressure to make an early, and then you make a diagnosis of a child. Wrong diagnosis can be so detrimental to the child's morale and the future directions too. It's quite a big pressure. Then the shift in labeling with autism before was intellectual disability as a primary diagnosis, and then funding links to autism, an increase in diagnosis and self-diagnosis. This is one condition that people come saying that I've got autism, I've got ADHD, I need medication. And very opposite to the normal. When you say that a person has schizophrenia, they don't want to hear that, but here they're coming with that diagnosis. The major clinical presentation, though, would be severe emotional dysregulation. Somehow, I've seen, 20 years ago, when I was in India, we saw such emotional dysregulation in children who have been severely abused. But here, the level of emotional violence and emotional dysregulation is unbelievable. Sometimes the whole class is to be evacuated, police to be called, because the teachers are not allowed to use any corporal punishment. So if a child gets dysregulated, the whole class has to be evacuated. So presence with diagnosis of opposition defiant disorder, harm to self and others. And the other big problem, I'm sure that you're facing it in India as well, is total social disconnection, social avoidance, and lost in the cyber world. Emotional dysregulation, acting out behavior is easier to manage than the social disconnection. Now, most of the outcome studies, what are they showing? That despite improvement in symptom, outcome, and social inclusions are not very strong. About 60% are living at home with a disability pension, and those with jobs, many only just few hours a week. Level of social and occupational engagement by the age of 30 is a predictor of the level of engagement for rest of life. And most recent studies, including meta-analysis, shows that about 50% of them are having poor outcome. Peer relationship, parent report of peer relationship shows about 50% have no peer relationships, and about almost 75% of them have very poor peer relationships. Predictor of having peer relationships is younger age and less impairment in social interactions. Outcome of employment, this is very interesting, very interesting. Definitely low rates of employment, but autism without intellectual disability. People who have got intellectual disability, they go into sheltered workshops and stuff like that. They've got better, but without intellectual disability are 3 times more likely to have no daytime activities compared to adults with an ID. This is very interesting. And post-secondary employment, so after school, the employment situation is actually really poor. The autism and family burden, higher levels of caregivers stress, depression than caregivers of young adults with intellectual disability or ADHD alone. Level of stress is comparable to persons caring for individuals with brain injury. And the concerns on high dependency on elderly parents. So these individuals, when they are growing older, when the parents are getting older, what will happen to these children? Often the other siblings are estranged. Often they have got only one child and the parents are becoming elderly. In Australia, there's NDI's National Disability Insurance Scheme, which is one of the unique things that this country has. No other country has this sort of unique system, which still, with millions of dollars being put into it, is not good enough. So who will look after these people when they grow older? And about 30 to 50 parental mental illness, 30%, 30 to 50% of the parents also have mental illness. Now, the research on personality disorders and neurodevelopmental disorders, there is some literature on cluster A, especially schizoid and schizotypal, and cluster C, anxious avoidant personality disorder or with autism, which is not very difficult to understand. But the main clinical interest is in cluster B, because that is what we are seeing a lot. And till recently, I mean, there have been such a dearth of literature on cluster B. The combination of neurodevelopmental disorder, developmental trauma, emotional dysregulation, and emerging personality disorders, especially borderline personality disorder, is quite what we see. We can see this is happening, but there is such a difficulty in this area of research is not that prominent. And I will give you an example, first case example. This is a patient that was referred to us for an assessment. He was from an Anglo-Indian background. The mother lives with a mother, full biological mother, and stepfather, and stepfather and two half siblings, both of them boys. He grew up mainly in Middle East. Mother was a dentist there. He was subjected to severe emotional abuse. There was a lot of domestic violence. He was also sexually abused by his father, who was also from an Anglo-Indian background, from Bangalore, and the father also experienced severe abuse in his childhood as well. So he migrates with his, the mother escapes the domestic violence situation, marries a Sri Lankan man, comes to Australia, where he had significant problems, which was seen as a result of domestic violence and, just a brown child lost in the white world, that sort of a situation. He did not do really well in his studies, somehow got into nursing. And as a young adult, he started bodybuilding. He was using some illicit substances, which was associated with bulking up his muscles and all. He got into trouble. He presented with suicidal ideation to the youth team, where they made a diagnosis of narcissistic personality and depression. Things were not improving. It was very difficult to engage. Psychotherapy was proving impossible. When this question of autism spectrum disorder was raised, we saw the patient. It was quite apparent that there was significant family complexities. His uncle was diagnosed with childhood schizophrenia when in Middle East. He was re-diagnosed as schizotypal personality disorder when he came to NIMHANS. His uncle lives in a sheltered accommodation. Most probably the uncle also has autism spectrum disorder. Mom changed her profession from dentistry to a psychologist. She is an expert in autism spectrum disorder, but her opinion on the child was seen as a biased opinion, and she could not get a diagnosis. But after going through our clinic, seeing his problem from an autism lens could really help not only the child but everyone around him. His conflicts with his stepfather would be so very black and white. He would make unnecessary comments on Facebook about things which are politically totally incorrect, and then get into major problem. But gradually looking at his problem from an autism lens made him understand his difficulties, and others understand him much better. The second case, she was a 15-year-old girl who presented with 2 years of school refusal and significant self-harm and violence towards mom. And she had inability to make and maintain friendship. She had significant bullying at school. She again experienced severe domestic violence from a biological father towards her mother, ongoing severe conflict with the child. She was diagnosed with complex post-traumatic stress disorder and borderline personality disorder, and she was discharged from ELMS. She was having all this pseudo-psychotic-like symptoms. Saw a private psychiatrist who diagnosed her with schizoaffective disorder at the age of 15. put on anti-mood stabilizer, sodium valproate and lurasidone at a very high dose, and there was no improvement. She came back at the age of 17, and again re-diagnosed with borderline personality disorder. And on further delving, we did a lot of family therapy, things became much better. But on further delving, what was revealed was that she definitely had an undiagnosed autism spectrum disorder and ADHD, which was never addressed. Then there's reformulation and understanding the difficulty from a neurodevelopmental lens, and then treating her ADHD um, uh, with Vyvanse, lisdexamfetamine, made a huge difference. Suddenly she said that the cloud in my head has just moved. I can focus better. I can think better. And the emotional dysregulation was much well controlled when the ADHD was treated. Now, with this, let us talk about understanding emotional dysregulation in child psychiatry. It is transdiagnostic and so ill-defined, and I'm sure that you are all aware of this prepubertal bipolar controversy, and Dr. Lieberman, got getting into trouble, where children as young as 2 years old in America was being diagnosed with pediatric bipolar. But when children are presenting with severe emotional dysregulation, it's very difficult. Is it temperament? Is this post-traumatic stress disorder, neurodevelopmental difficulties, interpersonal functioning? And I can talk about this for hours together. The DMDD, the dysregulated mood disorder with dysphoria, being introduced into DSM-5 without any field trials, without any with a very poor to stop the overdiagnosis of prepubertal bipolar. The whole issue about developmental trauma, opposition defiant, and emotional dysregulation diagnosis, which is being introduced in ICD-11. So this whole conundrum of emotional dysregulation in child psychiatry, which actually evolves from childhood to adolescence to adulthood, and as an adult they will get a diagnosis of personality disorder. But what happens to them, and often they're associated with neurodevelopmental disorders. Now, if you think about the biosocial theory of borderline personality disorder, it's the interaction between emotional sensitivity and an invalidating environment, which results in pervasive emotional dysregulation. And what is an invalidating environment? It may not necessarily be a physically or emotionally abusive environment. Many cases, it is good enough parenting turn invalidating, critical, judgmental, retaliatory, through a transaction between what the child needs and the parental inability to meet these needs. This invalidating environment pervasively negates or dismisses behavior independent of its actual validity. Now, the effect of an invalidating environment, it can cause further dysregulation, not learn how to tolerate distress, not learn how to label their emotions accurately, regulate their emotional arousal, not learn how to trust their emotion as reasonable response to events. Over time, those with emotional sensitivity learn to invalidate themselves. The self-invalidation happens. They tend to rely on others to tell them what is right way to respond to a stimuli. They tend to oversimplify the ease of solving life's problems, actively self-invalidate, and search the social environment for cues how to respond, oscillate between emotional inhibition and extreme emotional styles, from unrealistic goals and expectations of self and others. Now, this is a diagram from early origins to the clinical disorder, from the infant temperament, insufficient co-regulation and social communication with the parent, abusive and withdrawing carers, to the social cognitions of hypermentalization deficits. I will be talking a lot about it. And then there's emotional dysregulation, intense response and slow return to the baseline. then interpersonal, cognitive, and emotional problems leading to borderline personality disorder. And then there is this whole thing about shame, and this is very, very common in India and Indian families in the West as well, especially people from the subcontinent. There's the sense of shame. If a child is not being able to really do well, the whole family feels ashamed. If the child's results in higher secondary or matric is not good enough, the entire sense of shame that can happen. And just imagine a child with learning disability, the amount of shame that they have to endure on a daily basis, where they're stuck, they cannot move, and that leads to this toxic shame. But then the antidote for shame is empathy. From the autism spectrum disorder, as you know, there are lots of epigenetic phenomena that works along with the genetic disposition for the formation of autism. I'll be talking mainly focusing on girls, because often girls are undiagnosed and underdiagnosed. They're often present with secondary conditions like anxiety and depression, and then self-harm behavior. As soon as they start self-harming, the diagnosis is borderline personality disorder. We tend to label them with more of borderline personality disorder and emotional regulation difficulties, and then sometimes we are trying to manage the self-harm and then not being able to really see what is actually causing the distress in the child. The female phenotype from a the clinician's expression would be some communication difficulties. They might be less socially disruptive. They may be more passive. They learn by mimicry, use social models more. They are less mature than others, but not as odd as the boys. So they can really camouflage. They can be perfectionists. They can have a friend. And they can be like a chameleon, try to fit in. There's lots of camouflaging and social mimicry that goes on, and hence they can really flew under the radar. Now, I don't know whether this is a phenomenon. I know that Amrit is keenly associated with the LGBTQ group and also transgender, issues. But here, the transgender, the sex change clinics, we have got specialist clinics like that. The waiting list is more than 2 years in some of the clinics, and there is a high preponderance of children with neurodevelopmental disorders presenting in these clinics with the comorbidity of gender dysphoria and transgender. It's a full topic in itself. Now, ASD in girls, clinical implications. Girls are diagnosed later than boys. And as you can see, there is that sort of a 700% increase in the last decade or so. Girls require greater impairment in core and associated features to receive a diagnosis. Girls are less likely to receive a diagnosis after being referred for an evaluation. And autism diagnoses are often secondary to comorbid diagnosis of obsessive compulsive disorder, eating disorder, anorexia nervosa. When during this lockdown, Melbourne had the highest number of days of lockdown, more than 200 days in 2021. The eating disorder cases have gone up like anything. And then there's a comorbid autism spectrum disorder. It becomes a nightmare. Then with personality disorder, selective mutism, anxiety, depression, and gender identity. Very important to understand this 2-hit model and why it becomes a major problem during adolescence. So with the first hit and early intervention, there is some sort of an improvement during the latency period, and then the pubertal hormones and adolescence happens. The other children develop much faster, and then some of the tasks of adolescence are so difficult to find a partner, to make friends, to measure up. They become so difficult at that point of time, and then this major failures for transition into adult roles. And herein there is so much of invalidation and conflicts and emotional dysregulation, and then distress and presentations like personality disorder presentations. But the personality disorder is picked up, and autism sometimes is not picked up if there is so much of social camouflaging happening. The social emotional processing and the neurobiology of that. I mean, there have been a huge number of, I can talk about that, about amygdala and the size of amygdala, what happens with the changes in the size of amygdala in autism, and there are so much of relationship between the changes in the amygdala and emotional neglect and trauma. So there is huge amount of the social brain is impacted both in autism and in borderline personality disorder uh, as well, and trauma. The psychiatric comorbidities of autism spectrum disorder includes anxiety, depression, ADHD is a big one, opposition defiant disorder, uh, sleep disorders, eating disorders, tic, elimination disorders, and psychosis in older teens and personality disorders. Um, DSM-5 has definitely allowed ADHD as a comorbidity, and it was so shocking that it was not allowed for so many years, and hence, the follow-up of what is going to happen will be very interesting. The co-occurrence is associated with reduced quality of life, increased behavioral problems, poorer relationships, and family stress. About 60% of children with the diagnosis of ADHD, and the diagnosis of ADHD, especially in boys, precedes the diagnosis of ASD. And if there is significant executive functioning problem, perspective taking will be impacted. The other person does not have the chance to think about the other person. If the person is only talking about themselves, they cannot. So the core ADHD symptoms can also impact the ASD symptoms as well. The ADHD can have an impact on learning, communication, perspective taking, impulsive emotion, academic functioning, chronic invalidation, and then cumulative trauma. I don't know whether, how many of you are aware of this construct, but this has been, I've been thinking of this for so many years until this whole construct has come into rejection sensitive dysphoria, constant invalidation. At school, there is invalidation. He forgets everything. If a child has got impulse control problem, he will be micromanaged. If there is a parent with ADHD and a child with ADHD, it's a nightmare. It's a nightmare situation, total disorganization and chaos. But the opposite, if it is happening, the mother has OCD and the child obsessiveness, and the mother has an obsessive temperament and perfectionism, and the child at ADHD, the invalidation that happens throughout school and then coming back home, that can lead to such significant problems of feeling rejected, being undermined, being tired of being underestimated. And then this pathological self-doubt that can happen that leads to rejection sensitive. And if there is any hint of anything going wrong, they can just go into this overdrive of negativity and become very sensitive. So it is almost like an intermittent state between ADHD and that with neurodiversity. It can happen in specific learning disability, coordination problems. It can happen with autism spectrum disorder, eye functioning. It's almost like, there is so much of problems with symptomatic, in symptoms with post-traumatic, especially complex PTSD and ADHD. Emotional dysregulation in ADHD can be due to this attention, due to the frontal lobe dysfunction, and premature exit, resulting in chronic emotional dysregulation. So this is one major area that needs to be really developed, because role of emotions in ADHD is a very under-researched area, and a lot of it is still not in the diagnostic system. But impulsivity can be an impulsive emotion. They can be emotionally lot immature than people of the same age. This is a complicated diagram, but it can really show what happens with a child's development, poor cognitive control and emotional regulation difficulties, then behavioral difficulties, then parenting. The parenting can be with negative expressed emotions, coercive, or a permissive style of parenting that can have an impact. Then the conflict between the parents, and parental ADHD, addiction, bipolar spectrum disorder, can have an impact on the childhood predisposition, temperamental problems. So the interaction between the child, family, extended family, the parental construct, if there's transgenerational problem, what the grandmothers, if the mother is having ADHD and have been micromanaged by the by the grandparents, how they would implement their parenting on the child, it becomes quite a chaos. And if there are two other children with similar problems, it's a situation where nightmares are made of. There is such a substantial, I mean, so as you can imagine, children with the neurodevelopmental difficulties are much more prone to have more trauma. During my early part of my child psychiatric career in this country, there was this sort of a divide, people with autism versus people with trauma, and as if we are trying to divide between the two. But more and more, the realization is that children with neurodevelopmental disorder will have more experience of trauma, and which can be genetic and environment. So if a parent has a neurodevelopmental disorder, they would create an environment which will cause more invalidation and more trauma in the child. But adverse childhood events can lead to disrupted neurodevelopment and social, emotional, and cognitive impairment, and adoption of high risk behavior with disease, disability, and social problems, and early death. So this as we can see that, with autism, there are early death. In ADHD, there is early death. And so neurodevelopmental disorder as such can bring in more adverse events and can have all sorts of negative outcomes. That shows how childhood, it can really change the epigenetic changes that can happen. This is another complex diagram that shows how the gene environment, early childhood maltreatment, harsh parenting, interacting with the genetic environment, the genetic vulnerability, the temperamental characteristics, and how it impacts on the structural changes of gray matter, white matter changes. And then from a psychological construct, poor mentalization, emotional recognition, and executive functioning, resulting in difficulties in interpersonal domain, emotional domain, behavioral domain, and cognitive domain, resulting in the manifestation of borderline personality disorder. So the most important thing that I've realized, and I often preach, and this is what I write, is this formulation. I've got published articles on this, which is quite well quoted, on the necessity of this formulation. We need to have an integral approach. It is not this versus that. A biopsychosocial cultural formulation, which can be transdiagnostic, at times transgenerational, because if the parents also have been harshly parented, they can be very harsh as well, and that can have a big impact. It is to be interpersonal and sometimes bidirectional, because the impact of the child's behavior on the parents, 50% of them have a mental illness themselves. And because all these things are important in how we deliver services. The role of infancy and early attachment in this is also very important. I will actually talk a little bit about mentalization. I know I will leave about 20 minutes for questioning. Mentalization, because this is very important, and because these mentalization deficits are seen in people who have undergone childhood trauma and borderline personality disorder. And with autism spectrum disorder, people have problems with mentalization. They are hardwired not to mentalize. So mentalization is attending to mental states of self and others, holding the mind in mind, mindfulness of mind, understanding the misunderstandings. And this is the last one, is what I often say, seeing oneself from the outside and the ability to see the others from the inside. Now, this is it has been published in February 2021 about, it's an excellent article. If anyone wants this, just let me know. I will send it to you. This is a empathy, mentalization, and theory of mind in borderline personality disorder and possible overlap. There's hypermentalization and in borderline personality disorder, and the similar sort of a problem with autism, and especially children with high functioning, if they have had lots of negative events in life, they will hypermentalize. They will often go into this over mentalizing state, and that can get them into more trouble. There's another study later on. I think there's Baron Cohen here as well in that study, which we're judging autism questioned in borderline personality disorder. Is a high increase of autism question in borderline personality disorder. The people with only borderline personality disorder have a better EQ, emotional quotient. With autism, just autism, there is increase in autism quotient and poor EQ. That is the difference. But where is this is mentalization, thoughts, feelings about others. Here is empathy. And empathy can be cognitive and affective. In autism, sometimes this online intuitive empathy might be lacking, but when they get it, they can get it. In psychopathy, on the other hand, there is the cognitive empathy. They get what is going on, but they don't give a damn. So that is the difference, the classic difference between psychopathy and autism. There is criminality in autism and serial killers. That's totally another story. And I'm leaving it. I'm not going into that today, but if anyone is interested, there are lots of literature on that as well, on autism spectrum disorder and psychopathy. Social cognition, theory of mind and perspective taking. In autism, we have mind blindness, but if there is severe trauma in the childhood, there will be mind blindness as well. You cannot, the whole world, the picture of the world is totally biased towards, they cannot think about the mind of the others because of traumatic experiences. The mentalization and mindfulness, and there is an overlap. Now, one of my major areas of interest, because my area of interest is working with children with parents with mental illness. And here, this really, sometimes we see people, in my caseload, I have at least have 2 or 3 parents with autism, with a child with autism, and it's a nightmare situation. Now, the MBTF, this is mentalization based psychotherapy, MBTF, really gives you a great understanding about what happens when there is powerful emotion. When someone is angry, that leads to poor mentalization, inability to understand or even pay attention to the feelings of others. Other person seems incomprehensible. Then you're trying to control the other person. The other person seems frightening, undermining, frustrating, and distressing, and you take coercive action that leads to powerful emotion in another person. In a parent-child dyad, it's often happens. The parent says, "Don't stop playing the video game." The child, and the more the child becomes more resistive, the parents start saying, "If you take it, I will rip off the thing. I will take the things off," and that results in absolute chaos in the household. So this MBTF model can be quite helpful in working in a dyad. The individual psychotherapy, sometimes you can do it forever, but if you are not really empowering the parents to work on this, that can be problematic. So using MBTF and with a twigging a little bit, with keeping in mind that with autism there needs to be a bit of a twigging, it can be really very helpful. The other way of really thing is dialectical behavior therapy, DBT-A and DBT-C, where the interaction between the child and the parent is seen together. That the children have high emotional vulnerability, and event triggers judgments. The judgments leads to heightened emotions, expression of emotions, secondary emotions like anger, and then shame, and then inaccurate expression of emotions, and then invalidating responses that leads to problem. But this model where there is this interaction between the child and the parent in DBT-A and DBT-C that we use the parents and the children for coaching emotional regulation skills. Now, these are some of the books that can be of great help, especially this one, because emotional dysregulation happens in an interpersonal context. When we are really understanding that, it is the parental emotional dysregulation or the partner's emotional dysregulation happening together. and Alan Fawzetti has number of articles on the psychosocial theories of borderline personality disorder. And this book by Dixon Bevington and Peter Fonagy on the integrative treatment of borderline personality disorder, but it can be adopted with there's a whole website on training called Ambit, which can be easily seen through YouTube. That can be quite helpful. We use this book, collaborative problem solving techniques by Ross Green, in our clinical work in dealing with severe emotional dysregulation with children. With that, I come to the end of the presentation. Thank you for bearing with me, and I'm more than happy to take questions.
Thank you, sir. Thank you so much for such a lucid, eye-opening, I think, presentation.
Thank you, sir. I call it as a voracious presentation. Still, we have the appetite, though it is dinner time. It was wonderful presentation, sir. Very lucid. With this comprehensive presentation, we could navigate through the transition of NDD into personality disorders and into adulthood. So it was very clear. The transition was very clear. Can we take questions now?
Yeah, thank you, Chairperson. Amrit?
Alim, you start.
Yeah, Soumya sir, thank you so much. Many questions are there in the chat box, some in the personal inbox also. Very important question: how to screen for such adolescents in school programs, those who have missed a diagnosis. And there is a related question in adults: how will these symptoms present? So basically, if these symptoms are missed in the childhood, how will they present in early adolescence and later part of adolescence?
Fantastic question. I mean, this is one of that major problem, the demand capacity model. Lots of adults misdiagnosed. 7 out of 10 adults with ADHD. I'm talking about ADHD first. First, I'm talking about ADHD, then I'll talk about ASD. 7 out of 10 adults don't. It's a demand capacity. Some people, and it's also. I mean, can I be a bit cheeky? In Indian situations, often this can be diagnosed. I mean, you have got maid servants, you have got drivers, you have got a gardener. In Australia, you can make out this person is disorganized. The front lawn will make you believe that this person is disorganized. It is, you go to the suburbs where we've got this mental health problem. One person who's got mental health difficulties, you can see that they are, I mean, because you have to do so much of multitasking that it is so difficult. So so demand capacity, when a person can go through education, then when there is multitasking, they fall apart. It is attention resource allocation problem, isn't it? It is not attention deficit. It is about the frontal executive functioning that becomes a problem. When the demand is more, then they can start falling apart. And then you can see that when you go into the childhood, the mother was doing everything for this child. The child had to sit down and study. But as soon as he has to become an adult, go to university and do many things on his own, the child is falling apart. So the executive functioning. So inattentive ADHD is often missed. Inattentive ADHD, also, especially in girls, can result in internalizing problems, and that can be missed. This is a clinical conundrum, and here we have this perfect mix of inattentiveness and also easy distractibility and the screen time and and the stimulation. They can do things in small bursts. So when it is highly structured, they can easily do things. That is missed. So that is this ADHD conundrum. There's a beautiful book called ADHD 2.0. It's a beautiful book written by 2 psychiatrists from a personal. They also have ADHD themselves, so it's very well written about the conundrum. And then the pathological procrastination. That I can't do it. because I will make a mistake. And then is all this sort of a superego talk going on in their background. If I make a mistake, this is what is, I mean, all the stories of their fathers, mothers, professors have will come back, and this pathological process of overthinking, overanalyzing, and then going into this negative spin, which is often present. This is just ADHD. The with autism spectrum disorder diagnosis, with girls especially, the early childhood history of lack of humor, not being able to understand what is going on, there was this child that I saw, the intuitively understanding the other person's perspective. The mother was just emotionally upset. The child did not know how to really respond to that emotional difficulty. And then the child comes a little later and saying that, I'm so sad, mommy, I don't know what to do in a situation like that. So this the social and emotional reciprocity, the first criteria, that this online reciprocity is a problem, and also perspective taking, not being able to intuitively take the other person's perspective, that is a problem. And friendships, they can either dominate the friendship or be a follower, but this reciprocity is lacking, and that is a problem. Then in conversation, they can drag the conversation to their topics of interest, going, I mean, a huge amount of interest in one area, but cannot have other perspectives. So those are and then sensory sensitivity is a huge thing, I mean, sensory sensitivity to noise, touch, temperature, coordination difficulties, a huge problem with coordination difficulty. Handwriting can be very poor. Then they can also have this non-verbal learning disability like profile, where they can read and write but cannot comprehend. So but entire education is all about comprehension, isn't it? Wow, they read a poetry, and when you're telling them how do you summarize it, they can't summarize. They can draw well, they can copy well, but they cannot draw with imagination. So that becomes a problem. So often these kids with high functioning autism spectrum disorder can be spectacularly good in maths. Anything that is to be deduced, maths can be very good. History, they can be very good, but English essay can be a major problem, because essay has to be deconstructed, right? Because if they know the answer, they can solve. But if in essay you don't know the answer, you have to really construct. But there they can have a major problem. So these are some of these features with high functioning individuals where they can have problems that can be missed.
Yeah, so sir, in a lay person's language, if I say certain eccentricities that are there, so you have to catch those and then you have to
The
reduce on them.
eccentricities are there, but the socialization, the thing is, the nuanced socialization is problematic. The free flowing conversation is difficult. The person can talk solo on their own perspective, not being able to listen to you, and you can see that the sense of humor can be a bit problematic. Non-verbal language, they don't understand. Facial expressions, they don't understand. They can have the other main problem is facial expression. They can have a very flat face. So you won't be able to understand that the child is getting angry. And that's why there can be so much of severe emotional distress. So you cannot understand whether the child is getting upset or not. And then from 0 to 100, suddenly there is violence, but you are not being able to predict that this child is getting angry, so that is a big problem, understanding facial expression, body gestures, and expression of that as well. So very difficult to predict, very flat faces.
There are two raised hands, Dr. Subhas and Dr. Jalpa Bhutta. Can we take questions from them? And then
Yeah, I think I'm inviting Dr. Jalpa. And Soumya sir, thank you so much. ये जो आपने बताया है, these are such a fine points. I think we need to be taught in again and again regarding this. Dr. Jalpa, ma'am.
Yeah, hi. Can you hear me?
Yes, ma'am.
Yeah, hi, Dr. Basu. It was a fantastic presentation, and you hit spot on very, very complex areas in a very beautiful and concise way without, rambling too much about it. So basically, I worked in the UK up till 2008, but right now I'm in India, and most of the concepts that you said are very new out here in India, especially when you say a person having ASD plus personality disorder and can even manifest with comorbid psychosis. So there are several diagnostic dilemmas, like you see OCD with ADHD. Again, it's so difficult to tease out. Then what you rightly mentioned, the high functioning ASD who may present, who may have occupational difficulties. Like one of my patients, he went into science stream, but he was high functioning, so he didn't fit in anywhere. So more of a comment than a question. Thank you so much, Dr. Basu, and I hope that we keep hearing more and more lectures from you. This was absolutely brilliant. Thank you very much.
I'm really grateful for you for this comment, because you've worked in UK. You will understand difficulty. I mean, there is the Coventry grid. I mean, this is you can just Google Coventry grid. In UK, this is when I went for an UK interview. They asked me, how do you set up an autism clinic? Autism was my area of interest even in India, and I just rattled up everything. But the criticism was that I did not say that attachment disorder and neglect can be a differential diagnosis. I've never seen such a neglect before coming to Australia, because our child psychiatry is very middle class child psychiatry in India. We don't have community child psychiatry, so we have not worked with orphanages and children with severe trauma that is there.
Absolutely.
But in
Yes,
in a socialized health system like UK and Australia, you're dealing with that, major social difficulties, and the
absolutely.
impact of that on the children's mental health. So
Yes, and I remember you
uh,
even mentioned chronic PTSD along with, ASD and emotional dysregulation. And yes, it is very complex. And these
yeah,
are major diagnostic dilemmas. I hope we talk much, much more about these, all of us together. Thank you.
Thank you so much, ma'am. Gautam
Gautam
da.
bhai, Gautam bhai.
Hello,
hi
Sir,
fantastic,
boss, how are
Shammo.
you?
Shammo, fantastic. I am really proud of you. I, it was an excellent deliberation. In fact, I was listening almost all the today, total your lecture, and it was fantastic. I think
Thank you,
IPS should
boss.
utilize you much more than what we are utilized till now.
One thing I have to tell you is we are six of us, 6 or 7 of child psychiatrists in Australia. We we have formed a group and we try to really work. We have a program that we are doing, from Coimbatore. Purpavai, runs that program. All of us are totally committed for the Indian cause, and it will be just more than. It's 3 o'clock at night today, and I can imagine that without
thank you so much,
caring
sir.
for my country, I wouldn't be doing this. And all of my friends who are in this group would be more than happy to really join in with the IPS for the cause of child psychiatry, especially the community child psychiatry, training of the trainers. Both Amrit and Aleem knows that in child psychiatry in CIP, I really ran that, started the community child psychiatry program and I have implemented that in Victoria as well, working with pediatricians, working with school psychologists, working together as a team. We can't do child psychiatry just as psychiatrists. It's impossible. It has to be working with uh, all the health providers, working with Anganwadi, people. Both of them, I have, when I go to India, sometimes I do clinics, uh, and the patients who come are exactly like the patients in Australia. When you say that a child psychiatrist is coming in community, like in a village, they present with exactly the same cases: domestic violence between mom and dad, alcoholic child, alcoholic father, the child is presenting with school refusal and emotional dysregulation, which will not, very similar to the present, but we don't have a, we need to really channelize whatever we have at the grassroots level, preventative mental health, with Anganwadi workers, infant mental health, that level at a lowest, at the ground level. Because I remember in CIP we used to do this epilepsy program and child mental health awareness programs. The smartest people are working at the grassroots level. We need to really do
Absolutely.
something. Yeah.
We'll plan. Bye. I'll talk to you later.
I'm more than
Great job
happy to.
you are doing really great job. So proud of you.
Thank you.
Yeah,
Subhash sir.
And thanks to definitely Dr. Tufan Poti and my two brothers, Samrit and Ali, because you are doing a great job. It is the only, I think, only webinar which is sustaining right now.
this is India's longest
Every
running
week.
webinar.
Great job,
Medical
Amrita
field.
and Dr. Tufan Poti.
Diamond Jubilee next time.
There are, sir,
Achha,
Dr. Subhash,
as I have propped in, I have a question for Dr. Basu. Sumitra.
Yes, please, sir.
So, do you find any variation in the indigenous population which form a quite big part and they are also quite researched in Australia?
So that is my second area of interest. My main area of interest of work is in child psychiatry. I mean, in autism and ADHD. But the second is on indigenous populations and on migrant populations. So that's my second area of interest. So it's a huge issue. The indigenous population is the most traumatized people in the whole world, and
That
their
is
stories
correct.
are not told. They have got this stolen generation. Anyone with a white blood was stolen from their parents and raised by white families. So the presentations are they are inherently anxious and of coming to mental health. So when they present with more severe problems, more severe emotional dysregulation, more severe conduct disorder, and then the family history is so muddled up and complicated. Domestic violence, exposure to difficulties, parents with mental illness, parents with substance use, parents in custody, jail, sexual abuse. So it is a mixture of severe externalizing behavior and family chaos that we see with the indigenous population. And as you have this is a most brilliant question, because the indigenous suicide rates between in the last 4 decades have gone skyrocketed in Australia. The youth suicide in the indigenous population is a major problem that we have, and they don't want to engage with the Western system because they think that the children will be removed. So that's why it is a huge problem in the first world system. The indigenous mental health is a huge problem.
Sir, how will it help if I am able to catch NDDs early? What difference does it make if I ignore NDDs, if I include NDDs in early childhood?
I think when a child is present, I mean, if a child is presenting with severe emotional regulation difficulty and severe problems with, we need to do a full screen, which should include a good screen about NDD. And it's not just hyperactivity; it is impulsivity. And so with ADHD, there are 6 symptoms. Problems with hyperactivity, impulsivity, inattentiveness, but the other 3 are more important. Problems with planning, organization, time management. And so that has to be, I think it has to be screened for every child patient and adolescent especially presenting with emotional regulation
And sir,
difficulty.
in the endpoints, suppose a person is now adult. So what are the differences? What is the impact that we will be able to make in the interventions if I am able to catch early?
The whole life can change. This is one condition where the whole life can change. Early intervention can because first of all, with a early diagnosis with ADHD, I'm saying ADHD, not with autism. Autism, I will just say separately. The education program will be different. The child, they function very well with routine. If you change short, focused attention and with a reward. That can be that is how they need to function. You have to really and there is a beautiful book called 12 Principles of Raising a Child with ADHD by Professor Russell Barkley. Professor Russell Barkley, really, remember this name. He has got a huge number of YouTube videos on every little points about ADHD. And then the medication. This is one condition where the medications can be of dramatic effect. I mean, I recently had a patient from an Indian origin referred to me. I mean, he has gone through an Indian education system where he had a major problem, and then he went to UK where he was not diagnosed properly. In year 12, he came to see me. I diagnosed him, put him on medication, provided lots of validation, lots of psychological interventions and things like that. In year 12, he got a 97 point, some sort of a abnormal. He has never got more than 80% marks. He got some sort of it changed his whole life. I mean, changed his entire life, which, in prep, the school said that his father has to take, both the parents cannot work because one person has to look after the child. The father did that, but in year 12, he was falling apart. It can have a change in trajectory, especially with ADHD. With autism spectrum disorder, looking at, I mean, the child it cannot take perspective. He's rude. He can be crude. Without seeing it from an autism lens, the child will be seen as opposition defiant. He will be more and more invalidation that he will experience. But looking with a proper psychoeducation with the parents and working with that can have a life-changing experience. The parents can accept. There is a beautiful, poem that you can find it on the internet. It's called Visiting Holland. Visiting Holland. It is written by a mother with a child with autism spectrum disorder. It talks about radical acceptance, and that can have a big impact on how the child is perceived by the parent, the parental perception of the child, because or else the child is seen as, just imagine the child doesn't have emotional reciprocity. The parent says that he's ungrateful. He's so focused on himself. He's so selfish. He doesn't give anything back. But the entire perspective can change if the child is seen from a neurodevelopmental perspective, as you can imagine. And that can have such a validating response, and that can change their life trajectory.
Great, sir. Great.
Amrit, any questions from your side? You're not getting impulsive and hyperactive.
I will take one question about comorbidities and then we'll call sir again. We don't want to end everything.
I think so, sir. We have to call you again because there are too many questions.
There are a lot of informations and I think we need to work on them also. So there are two questions on comorbidity, which we have always asked you, sir. In ASD plus ADHD presentation, we see that ADHD masks ASD. How do we tease out the two and how important it is to diagnose both? Another question is about psychosis in ASD. What is your experience, sir?
The psychosis and ASD is this was one of the projects, especially schizotypal. Schizotypal personality cannot be diagnosed with ASD, and which is a absolute farcical, because we can schizotypal personality. I mean, this is DSM-5. Schizotypal is more of a schizophrenia spectrum than so with psychosis, their sensory sensitivities can be so I had a patient who would be going into psychosis while going into with autism spectrum disorder. He would think that he's Lion King. He's running like lion. He can see the visual hallucinations. I mean, almost as if he is immersed in that experience of a 3D experience of in the room with the psychotic symptoms can also have autistic themes. So the present psychopathology can be influenced by the underlying autism. So that can make you feel, is it autism or is it the psychosis? And there is a high chance of developing psychosis with autism, because of if you think about stress vulnerability as a model, there are genetic factors that are common, and also they have got more experience of stress, because of their history of trauma, bullying, negativity. They will be much more paranoid than others. So with autism spectrum disorder, there is much higher chance of going into psychosis, and the psychotic presentations are different. I had a patient, I have a patient, who is obsessed with getting on a bus and will going into places. When he becomes psychotic, his ritual, the restrictive repetitive behavior becomes extremely much more obsessive, and it becomes very difficult for them to get out of that. So the change in those basic presentation, there's deterioration in functioning, the restrictive repetitive behavior becoming more and more difficult to manage. These are all indicators of a person getting into a psychosis. And with the ADHD and ASD, brilliant question. They can, the ADHD is a treatable condition, and the ASD it needs to be understood. So to teasing out the symptoms are extremely important, and the treatment of ADHD can improve the symptoms of ASD. I mean, recently I had a child who was referred to us for our ASD. I mean, we have a neurodevelopmental assessment service. So we went through this whole program, thing, and the child was diagnosed with ADHD. And with the treatment of ADHD, the ASD symptoms definitely dramatically improved. The perspective taking became much better. The child had more time to think about the other person's thinking. Mentalization became better, and the autism symptoms, the severity of the autism symptoms looked much better to manage. So it is definitely important to make the comorbid diagnosis. And also with anxiety, I mean, the question that happens is the executive functioning a problem secondary to a anxiety disorder, or is it ADHD as such? So that becomes a big question. But teasing out the diagnosis is very important because it has a treatment implication.
Yeah. Sir,
Subhash sir is waiting. I think, sir.
Can you hear me?
Yes, sir.
But I can't see myself. I mean,
we are able
maybe
to
the
see you,
video is
sir.
not working. Doesn't matter. First of all, thank you, Soumya. After a long time,
My boss, after
not able to see.
You're my next door neighbor, boss.
Yeah, so thank you after such a long time. That the main reason I came here, not because of topic, but because of you.
Thank you.
And thanks everybody anyway, Dr. Pati and everybody. So fantastic talk as usual. I mean, something that is really very, very helpful for adult psychiatrists. I have been an adult psychiatrist throughout my life for the last 30 years or so. And I have this experience of different countries and continents like India, UAE, now UK. So I can sort of, give a little bit of perspective from that point of view. And yeah, I mean, the particular two issues that, in fact, my question was partly answered by you. Alim asked, if once we diagnose somebody, an adult with either ADHD or ASD, as you said very nicely at the end, that with ADHD we can treat and we can make a difference that way. And with ASD we can understand, we can still make a difference, isn't it? Understanding is a big part of making a difference. So that's what was the major sort of chunk that I will be taking home. I had seen few people with gender identity disorder and LGBTQ, that category. They had also, and they had that ASD symptoms. And that really created havoc in the system because the person, as you know, in the UK, you cannot refuse him certain services. He will be coming repeatedly without understanding, without actually tuning in to those contexts and social cues. And that was basically standing on his way of treatment. But as you said, I mean, the part of understanding it gives you a sense, otherwise you would think that, oh, he's probably some sort of obstinate type of person. So that's something I learned from your talk. And I know, thank you once again. It must be really late at night, as you said, 4 o'clock in the morning.
It was so lovely to see you, boss.
Thank you.
So lovely to see you, and thank you for just attending. It's an honor.
Yeah. Thank you so much.
Thank you,
Amrit,
Dr.
I think
Subhash,
we
for
should
your
wind
kind
up now.
We should
Sir.
hand over the session to Pani Bhai.
Funny bhai, your final comments. You have to unmute yourself.
Yeah, now am I audible?
Yes, sir.
Yeah. On an ending note, I just want to conclude with the words of Thomas Insel, the director of NIMH, as everybody knows. Psychiatrists actually believe that their diagnoses are real, but there's no reality. They are just constructs. And after listening to the presentation of Basu sir, the first step is to analyze the huge empathy, spectrum of empathy and diagnosis. What he was talking about, the transition right from childhood to the adulthood. So this is what I just want to conclude. Maybe the future of psychiatry is neurodevelopmental and child and adolescent psychiatry looks a promising branch. Okay. Okay, thanks a lot for inviting me as a chairperson. It was a wonderful feast listening to the speaker and the organizers organizing this academic feast. Thank you. Have a good day. Good night.
Thank you so much. Topan sir.
Thank you, Amrit. My discussion was, I wanted a little more complete interpretation about the Australian Aborigines. The view I hold is that this symptomatic presentation in indigenous populations may not be as we read in Kaplan, may not be. So when you think these symptoms transit and become another symptom in adulthood, it has to be thoroughly studied in detail. And one has to have a total contact with them, make a research. Because here in Odisha, I tried to translate Mini to a tribal language. There is a lot of problems, but at one point of time, we realized what the hell we are doing. They don't have any of these things. They don't call it by that name. The name by they call it is different. And because you are involved there, and because there is a good structure is coming up in Australia to take care of the indigenous people, previously it was not there. Although by that, the last report I had, 70% of the indigenous population has not been covered on the analysis of social and emotional behavior. They are left out, but it comes up, and if you take it up, maybe a lot things may come out to be in a totally different way. Because at that point, we must realize we are, as was being told by Dr. Subhas, we are yet to know the truth is coming out. We have left them.
Absolutely, sir. It's a huge area. It's a massive area. You know, I mean, the whole indigenous population of the entire world, you know, I mean, this is a totally conquered, actually, India treats the indigenous population much better than how, I mean, after working with indigenous populations here, I realize the value of freedom that we have, you know, because the way they were destroyed from corner to corner, it is this transgenerational cultural trauma, you know, and the thing that you just mentioned, you know, one of the Sudanese patients, I was doing this assessment with autism, he says, what is this autism in my language? We have got an ancient culture. Why don't we have this name in my culture? You know, it was such a shocking, you know, very difficult, very profound question, you know, to answer. And the presentations are different in a collectivist society versus an individualistic society.
Tufan sir, you are muted. Alim has muted you. Sir, you are muted. Yes, sir.
No, Alim ne mute kar diya. Now, in Australia, Dr. Bush and Dr. Niania, they have taken up a project which is a quite, maybe you must be aware, it's a quite appears to be a very synthesizing thing where we can get some data, scientific data. So all the best. I am also interested in tribal mental health in India, along with my guru is Dr. M.S.P.K. Raju. My partner is here, Amrit Patujose. We had organized the first tribal mental health seminar in India, but there are many things that are to be answered.
Absolutely.
Thank you. I appreciate your talk very much. I have been all throughout.
Thank you, sir. Have a
Thank you.
lovely new year, all of you.
Sir, I'll give the formal thank you. So let me thank Dr. Soumya Basu. At night 2 o'clock, the only time he's awake is when we are partying in CIP. So Soumya Basu has been, Dr. Soumya Basu or Soumya Da, a close family friend also. Sir, has been our mentor. We've learned child psychiatry. We've learned everything about child psychiatry from Dr. Soumya Basu. So full credit. If you look at child psychiatry unit and CIP also, he has been the mainstay of it along with Dr. V.K. Sinha. So thank you, sir, for coming and giving, I would want you to come again, sir, with a little smaller topic. I think for me, it was a little more information overload. It was so much things were there that we would have love to have you again, sir. Maybe 1 or 2 topics, if you don't mind. Maybe the timing is wrong, but then we would demand that for Indian Psychiatric Society. So thank you, sir, for coming, enlightening us and giving. So thank you again. Fanikan Bhai, thank you for chairing the session. You're the sole chairperson and you had to do the work of both chairpersons, and it was wonderful having you, seeing you so soon. Thank you, Dr.
sir.
Tufan sir, Alim, our whole, we had more than 330 participants today on a new year ending holiday season, webinar fatigue. Having 330 people is a feat in itself. It speaks a
What a
lot
great
about
way
the
to end the
speaker.
year.
Yeah, it speaks a lot about the speaker, the topic, and the trust people have in the whole team. So thank you everybody for joining us.
Yeah,
Next
and Dr. Sandeep Goyal, actually, he was not well, so he could not join. He just mentioned it in the evening.
So thank you, the Torrent team. So we'll have the 75th edition next week. Tufan sir, can you tell us about the topic? And then we'll close this.
Next speaker is Dr. E. Mohandas, and topic is Anopheles mosquito and magic bullet.
So before we close, Dr. Soumya sir, people have been asking for your email ID.
Sir, your email ID, if you can type in the chat box.
So
Your
people would
email
like
ID.
to connect with you, sir. Otherwise, Alim will give his own email ID.
I will give your email ID.
आता ही नहीं कोई email मेरे पास.
ईमेल पढ़ना आता है?
पढ़ाना आता है यार, वही चाहिए. लीडर करवाता है काम, करता नहीं. Thank you, sir. So, good night.
Good night.
Thank you, sir. Thank you, sir. Thank you so much. आपका पूरा रात हम लोगों ने बर्बाद किया है.
अरे मैं तो एक ही सिस्टम में लॉगिन किया, मेरे 2 नाम कैसे निकलता है पता नहीं.
सर कोई स्पैमर है आपके नाम पे.
Good night.
अलीम और ज्यादा बोलेगा तो सोम्य बासु सर का पूरा रात बर्बाद हो जाएगा. So good night. Happy New Year.
Thank
We'll
you.
meet next year.
Thanks a lot, everyone.
Thank you so much, sir. Thank you, Dr. Sanikan.
Good, yeah. Good
You
night,
too,
sir. Happy New Year, everyone.
Happy New Year to all of you.
Yeah.
Bye.
Thank you, Dada.
It was nice.
Thank you for sparing time at midnight. Thank you. Thank you so much.
Bye.
Thank you, Topan Pati, sir. See you soon.
See you.
Thank you, bhai. Sir, can we close the meeting now?
Yes.
Sir, with your permission, may I close the meeting now?
Yes, please.
Thank you.
Please close.